principles as they were laid out in National Digital Health Blueprint, and we all have a resolve that we will comply to all of this. If we have to comply to all the design principles that have been laid out, then the best way of going ahead is microservices. And by using microservices, we will be able to comply with everything that's out there. However, in the last 6 months, we've had an experience that many of the members of the SCA have found it very difficult to implement the microservices because it is, a big step in terms of technology, the next generation technologies, so to say, and you have a cost of change. So, and also given that, we have a COVID scenario and we have to accelerate a lot of implementation in terms of the interoperability, because today we need the data to be interoperable between different systems. What is beginning to happen is, the COVID positive cases, you're getting the lab tests in standard, L form, P form, S form, whatever, but then, the data which is from the hospitals, the COVID positive patients' data, is all stored in different formats and different HIS systems, and that is not becoming available for epidemiological analysis. If you have to bring all of it, then you have to massage the data, clean the data, and that's what a lot of agencies are doing. But imagine now if the cases begin to mount and go, and as we've crossed 40,000 cases, this task of cleaning up all this different data formats and bringing it to a standard format is a humongous task, and it may not be possible over time. So there is a demand, very clear demand. India is asking that, can we accelerate interoperability design principles as we have laid out, and put out the e-objects as a connector or as a medium for bringing the data from all these disparate sources to be able to do the analysis that is required in the current situation. So it's almost like a clarion call from the nation to all of us that, can you accelerate it? And so we are responding to that clarion call. We are saying we will accelerate it. We've worked on the provider e-objects, and the details are now being published. We put it out onto a blog called Open Bodhik, and we'll provide the links for that. I will switch to the different options as we came out with. We said, every sort of product company is at different stages of their own development. So some of them are having legacy systems, whereas the others are building new systems. So people who are building new systems, you do have the luxury of adopting the standards 100% or nearly 100%, whereas in legacy system, you may not have that luxury. So, and we've seen that, the bolt-on model, as we were saying, that microservices option as a bolt-on has proven difficult for legacy systems. Whereas for new systems, doing it the microservices way is the best option to go. So what we are saying is that, for the metadata compliance, so you should, if you're developing a new system, build your database as per the metadata standards. And if you're developing a new system, go the microservices way. If you're developing a new system, then, to produce the e-objects, the compliance will be nearly 100%, with very little translation layer on top of your microservices platform. So if you do this, that's the best option for a new system. However, you may have, and we've sort of, got that feedback from the market, that many of the product companies have come and said that we don't have the necessary skill sets on microservices, even though we may be building a new system. So we said, okay, then the second best option is to probably do RESTful APIs, and you build your system in whatever way you want, but build RESTful APIs, and then you will have to invest in building a translator layer on top to comply with the e-objects. So that is for the new system. For legacy systems, uh, the best option probably is RESTful APIs. So you build a bolt-on layer of RESTful APIs, and then you will also have to invest in the translator layer. It'll be a little bit of a heavy development there on the translator, but it'll be worth it to comply with the e-objects. The second best option will be microservices, as we've been saying that even for legacy systems, you can do microservices as a bolt-on, and then you do a strangle approach that module by module you strangle your legacy system and switch to the microservices. If you are going to go the RESTful API way, so then that's a sort of a solution for midterm. It's not a long-term solution, but it's a trade-off that today you are not able to take a decision, maybe because of a commitment that you have to your customer base or because of the cost of change, and you're not able to go the full hog as far as the microservices bolt-on layer is concerned, then you take a RESTful API bolt-on model and still be compliant to the e-objects. So this is sort of a mixed approach we came out with, and each one can choose a sort of a different path, but ultimately what we want from all of you is that you comply to the e-objects. Now, you have an unfair advantage of being part of the SCA, that you're getting e-objects on a platter, but also we are publishing it in the open market. So the open Bodhik is an open forum. Anybody can come and read it and comply with it. But the SCA members get an add-on advantage that for implementation there is a hand holding and everything else that we are doing. So I stop at that point and I will hand over to Priyanka to present the details on the e-object. Any questions you have, anything that you want to discuss on these different options, maybe we can have a separate session on, a technical session, that is, where our technical architects will be happy to guide you through different options. And, we will be happy to figure out what is the best option for you. So for, I'm not saying one is better than the other, but everyone is at a different stage of development, so you have to choose what's the best option for you. Over to you, Priyanka.
Thank you, Dr. Pankaj. I'll just share my screen first.
Priyanka, we can't hear you. Is it just me or?
Oh, I was on mute. I'm so sorry. Yeah. So I would directly jump on what these e-objects are and why did we feel the need, why e-objects should have been there in the first place. So it all started when the National Digital Health Blueprint got printed, was published for the public, in the public space for comments and to be able to implement and convey the thought of all the standards that were written and published. So during that time, when NDHB was published, there was also a report being published in Niti Aayog book on e-objects. E-objects are nothing but in technical term are JSON payloads, which have minimum information as per the scope defined for that particular e-object. We have done similar work for the e-claim part of it, but today we will be focusing more on provider objects. For example, if a patient goes from one facility to another, or he switches facility and applications, his information is always available as per consent in a standard format. So those are nothing but these e-objects. So in provider object space, there will be certain very critical e-objects, as we can see after COVID, even post-COVID, now we have to live with this demon. I don't know for how long. So now telemedicine is becoming very, very critical. And as per telemedicine guidelines, the doctor is responsible for maintaining the medical record of the patient. How? Because right now he cannot give a parcha to the patient, he won't be able to give a printout to the patient or a handwritten note. Now this is the real need, where he is required to maintain and to support his decision making on patient's condition, because you can see telemedicine guidelines are little rigid, and then the entire responsibility lies on the treating doctor. So these e-object can play a very critical role here. For example, one of the very simplest and most critical e-object is the encounter note. So the encounter note is nothing but a summary of a patient's visit using all the NDHB standards. So in other terms, these e-objects are nothing but packet of information, or we can call it envelope of information with a address on top of it. So these e-object from a high level are divided into two parts. First is header, which is the address, which will tell you or a receiver or sender that where was it generated, basically who generated it, the provider, who is, for whom it is, the patient, and the facility it got generated in. So the header will deal with all the unique identifiers that will identify the facility, the provider, and the patient uniquely. So this is the address that will carry information from one application to another on consent. Second, the detail part, which will always be encrypted, actually stores the entire clinical information about a patient. The minimum clinical information, which we can call all the active information, active condition, information on active conditions, active drugs, will be part of this, so that even if patient switches geographies or patient switches hospital, his minimum information that is required for the second provider to take a decision on are available. Krishan sir, do you want to add anything on top of this?
No, I think Priyanka, you have covered fine. So basically, these e-objects will be modeled as the JSON objects, which Priyanka has already mentioned. And NDHP report lays down FHIR to be used as a messaging standard going forward. So FHIR provides the resources as the logical unit of the record structures, that can be sent over the interoperability layer, and it defines the mechanism of kind of putting the bundles of these resources together to model any document. So here, for example, the e-prescription is like a document which contain a lot of segments, and each segment contain the specific information related to, for example, patient demographics or diagnosis or encounter. So all these are different segments, and each segment is a resource in FHIR terminology. So e-prescription is like a document which bundle all these resources together and sent it over the REST APIs. So that is the simplest definition of the e-provider.
Yes. So just to enable interoperability, what we have done is we have taken MDDS standards, elements from MDDS standards that are required to generate a minimum patient summary depending upon the type of e-object it is. For example, if it's e-prescription, it will have lesser segments. But if it's an encounter note, it will have more segments. And if it is a discharge summary, more elements and number of segments will increase. So depending upon the scope of the object, we have picked up relevant data elements and associated value sets. The problem in India is every application uses their own data set. They have their own master data values, their own drug list, their own codes, which is a major problem. What we have done is we have not only used the MDDS, which can form the base layer, or you can say the interoperability layer to bring in semantic interoperability. We have also used the recommended international standards like ICD, SNOMED. So we have recommended, okay, these value sets to be used. And MDDS itself gives you 140 code directories, which have standard value sets for the entire country. So if we implement the e-object as a desired output or as an input form, it will solve the problem of exchanging data in the same format with a common meaning. So on top of it, I would just want to add that how to implement this. This can be implemented in two ways. One, application, which are new application that are being built, or new telemedicine apps, smaller apps, consultation apps, or new product that will be built. This can be an input form. These e-objects can be an input form where you enter standard using the standard input value sets. You enter data for patient for her visit. But for legacy system, it is a desired output format. So in short, what will happen is, in legacy system, you might have your own information model. You might be storing the same element level detail in a different format. So you have to enable a translation layer or a technology to be able to generate these e-object, which will get stored as JSON object in your database, as well as whenever somebody else requests it. For example, you have referred a patient to another doctor. If he requests patient's last visit or encounter detail, you will be able to push this JSON object that the other application will also be able to consume using Fire Server. Any questions here?
Two questions, Priyanka. You said that we can generate and store, and then when someone requires it, we can send it to him. Instead of that, we can just, based on request, we can generate it on the fly and send it also, right? We can do that also.
Yeah, definitely. We can generate. So basically, there will be a layer on top of the system, which will do all the translation, conversion into Fire format.
Yeah, I got that. Yeah, I got that, Krishnan. I just wanted to ensure that we don't have to store and send it on request. We can always generate it on the fly, on request. Correct?
Yeah, that's correct.
Okay. I mean, depends on how many people are asking for the same data. If there are multiple frequencies, then it may be better to store the data and not regenerate it every time. But if the frequency of request for the same data is only once or twice, we can just generate it on the fly and send it up. Correct? That may be better.
If I can pitch in on that,
Yeah.
it may also be important to generate it once and keep it from a legal compliance perspective, because if it is a claim for a claim, say discharge summary is used for a claim,
okay,
and you generated it, submitted a claim, then it is sort of a legal document, and with a timestamp that at that point in time this is what you generated. Now tomorrow if the discharge summary changes, then you don't want that the object generated at that point in time changes.
Yeah, but I have it in my database, and it's the same record which is going to be converted into the JSON, right? So okay, but the database you're saying can be edited and changed. Is that what you're saying?
Yeah, from a legal compliance point of view, I agree with what Dr. Pankaj is saying, because according to legal guidelines, your data may on the database side may change, right? So you are in control of the data, but on the legal side, you have to basically timestamp it and save it at that particular instant.
Exactly.
So,
yeah. Okay, got it. The second question which I had actually should have been my first question is, whatever we are talking about is e-objects, and we've come up with this, you have come up with this e-object, this thing. My question is, has this been already implemented in some government application or something already, so that it is tested in terms of we know that it works? I mean, there are no chinks in it, or is it an evolving thing and which will evolve further? Which you understood?
So we are at the cutting edge of the technology right now. All of us are learning together. and some of the government players are in this call and in the SEA together with us. So CDAC, NIC, PHFI, and so we are all in it together.
Okay. So no, what I wanted to know is, has CDAC or someone else already implemented it? Is it a
CDAC,
working version there already? Is something that I wanted to know.
I think everybody is working on it at the same pace.
Okay.
Everybody's at the same stage, I guess so. But
Okay.
Chimaji is there if he wants to respond, or NIC. I'm not sure if Naveen ji is there.
Yes, I'm here. We are also working at the same pace. What Dr. Pankaj said is right.
Okay. Okay. Thanks for that. We can go ahead, Prem. Sorry.
So this is just an example, just a sample of what kind of information it will store. Like I have already explained, as per the scope of the document, you will store respective information about patients. So it will have segments like clinical brief. It basically deals, it's as simple as the PDF or the paper summary that we give to a patient when a patient visits. It's visit wise. So you generate this object and store it per visit, so that not only internally your system will have a longitudinal record of the patient visit, but when requested, it get linked with the patient consent. It can also be available to a referring doctor who needs to see his last record or his active conditions. A very critical part here is the how will applications put in the patient consent part, which is very, very important from NDHB perspective, because NDHB has given the power now from facilities to patient's hand of sharing his record. Earlier, whenever a patient used to request a record, hospitals could deny, but now they cannot deny. It is the patient's consent. If he's willing to share his document or his summary with another doctor, they are liable. They are basically the custodian of the summary, of the patient summary, but they have to release it on request, and hence it should be digitally available with them. That is the change that NDHB has brought in. This is just how going forward, if we start generating e-objects, or some of the application can consume and generate these e-objects, we will end up into a PHR platform for India, where the data can be aggregated not only for research, but for a continuity of care perspective. Similarly, all the vertical programs that coexist, they actually capture the same type of, if you ask me, from a design perspective, they try to capture the same information, same field. For example, diagnosis. Nikshay program also stores diagnosis. An Anmol program or RCH program also stores a diagnosis, which is the pregnancy stage. All these diagnoses are well coded in the ICD-10 or STOMED list. The problem is, when these systems were built, they were built how our paper forms look like: diagnosis of TB, diagnosis of HIV. We don't have to do that. So this is the change that these objects will bring in. The information can be extracted against the same fields using international standard, which are already recommended by NDHB. And hence data sharing will become more easy, will be easier. This is just what is current condition. Also, side by side, government would also be working on various registries, because the header part will basically come from these registries, which will be personal health identifier for patients, provider identifier, which is nothing but the registration or license number of the treating doctor, facility identifier. We already have multiple efforts gone into it. There is NIN, there is NHRA, there is Rohini for insurance. We have different, it's time to harmonize that. And a health worker, where vertical programs are considered, it's very, very critical to have a health worker registry, so that we know, even if a e-object is generated by an ASHA worker, because she went for a household visit to a pregnant woman by taking her current condition and refer her to a PHC, it will be required at that level also. So these are few things that we will need, but until we have these in place, your local identifiers and a concept called alternate ID, which is very clearly mentioned in MDDS, can be used. An alternate ID, there are two fields in MDDS which says alternate ID and alternate ID type. So just to have a primary key, just to link your patients with his other records that might be sitting in other system, you can always store patients' other IDs. Like for example, alternate ID type is Nikshay ID, and I store Nikshay ID in that field. And the size and format will only accept a Nikshay ID. It won't accept any other ID. So you design a system in that way using the alternate ID concept, because we don't have UHID today. Government hospitals and government schemes are still allowed to use Aadhaar, but private hospitals cannot use Aadhaar as a unique identifier. So I'll just directly jump in the detail of the eClaim object just to make you familiar with the structure. Can you see my screen?
Yeah, we can see.
Yeah. So this is the header part that you can see. I have put down segments. So this is the header part, which is a machine readable part of the e-object that won't be seen on the front end of the application, but it is the backend just to recognize the source system and person responsible for generating it. And where if there is a referral done using the same e-object, the referral details, basically referred facility ID and referred physician ID will also come, so that the consent automatically passes on to that person to be able to retrieve patient critical information.
This is an e-encounter object. Priyanka said e-claim because we've done so much of work on e-claims that it's become almost like second nature to us.
Yeah, sorry. This is an encounter object which will cater to all the visits, every visit a patient makes to a facility, a health facility, or it can be a visit by the health worker to a patient's household. So we'll just pick up some fields just to explain. For example, there is a UHID. I have provided data element labels which are provided in MDDS. We have also provided the FHIR label because it will be using multiple FHIR resources, and we can use a FHIR for integration and interoperability across. So this is how it is designed. I have provided, you don't even have to look at the MDDS PDF because I have already provided the size, format details here itself. And remark for clarifications. So for example, the header will have UHID, it will also have facility ID, it will have a license or registration ID of the doctor, because for telemedicine, if you look at the telemedicine guidelines, it is very, very critical, and it is a responsibility of the platform provider to ensure the authenticity and identification of the provider who will be using the application. So this becomes very, very critical. And these are auto-generated document type code. These are all auto-generated by your system because your system would know which kind of an object you are trying to generate. This is the document ID, which will ensure that is a unique object being generated every time for every encounter. And all the applications definitely have a visit creation module where you assign an episode and an encounter ID to patients' visits. So this will have all those information so that you can actually put a timeline view of patients' visits to any facility for healthcare. Rest in detail, what you will also see on the screen, or the doctor would want to see on the screen, are these title, which we already today have. We have patient registration service or module where we store patient demographics. So the titles will automatically get extracted from your patient registration microservice or module that you have. Because the same e-encounter object, if we don't want to use a specific e-prescription object, we can still use an encounter object with minimum information available to the pharmacy, to an e-pharmacy to place the order. Hence, patient address becomes critical because they have to deliver at patient's home. Then what we have also done is we have followed the structure that the telemedicine guidelines have prescribed, that a Clinical Establishment Act has prescribed, even the MCI structure of a summary, of a patient summary. But we have, on top of it, we have also aligned it to international standards or way of writing medical record, which is the SOAP note format. But it again follows the other recommended structure in India. So, for example, subjective information is something that is subjective to what patient is telling you. So, all the information like family history, patient's clinical history, chief complaints, everything will come here. We have given element IDs, and there will be, for example, if you want to capture a COVID screening details, the chief complaint or the symptom can come from ICD symptom list, which is very clearly given. So that irrespective of which system is capturing the information, you can always add multiple symptoms, not only the symptoms which are already recommended, but for an epidemic like this where we don't know what can be another new symptom, you can enable the entire ICD list. The textual or free text won't be allowed. Similarly, all the active condition, all active patient allergies, patient vitals for the last visit, not all visit, last visit, any observation, examination details. We have kept it very flexible. So you just have you just have to tell, okay, what is the system that was examined, but you can have your own template. We haven't restricted people here because every specialty will have their own template. And you can just put in here so that we can extract only the relevant information if there was an abnormality found in that particular system. So you just have to extract minimum information out of your entire examination template. You don't have to convert it completely. Similarly, diagnosis will come from ICD with all, even the active conditions. When we take patient clinical history, we also record comorbidities. They are again nothing but we'll use the same ICD-10 list because they are the active diagnosis which may be there for a longer time because they are chronic. So we have used, as you can see, we have used standards and we have also provided references to the element ID in MVVS. So even if you want to do a proof check, you can always go there and understand that field. Though we have made it so simple that you don't have to do this homework. We have done all the homework for you. And I'll just give you some example of some value sets. For example, this. If you can see, this is a code directory. Wherever there is applicable code directory or value set, there it starts with CD. CD are code directories, or you can call it master data, which are standardized for India. What we have also done is, with this e-object, we have also populated those code directories for your usage so that your developers can directly use it in another Excel with all the value sets in detail. For example, there is something called standard value sets code directories. We have already given that as part of this so that everything is in place. Example, you can see the drug class. This is just example of one of the code directories which has all these details. Is another examination type, inspection, palpation, percussion. So we have given everything handy to you. And similarly, all the orders that were made that are active for the patients in the last visit or the active visit can get captured here. This is the drug information, all the active drug that were prescribed for patient. And before accountability purpose, it will also capture the author details using the user ID login by which the person might have logged into the system. Yeah. Any questions here? So that I can hand over to Krishan and Ved for the technical implementation of it.
So, Priyanka, one question here, Sumit here. How do we manage the change management? Like, how is change management handled on the code directory side? Because in absence of an online service which is available for all the code sets and all the code directories, these will eventually have to be handled on the individual application side, right? All these code directories will have to be manually mapped, or master data will have to be managed at the application layer itself, right? Because there's no online service as of now, is what I understand from this discussion, right? So how are you guys handling, or how are you guys planning to tackle the change management on the code directory side?
Dr. Pankaj, you want to answer that?
So that's a good question. So some of the code directories are going to be left, to the market. and all the product and vendor community to sort of manage at their own levels, because these are master data, and some of it are going to be very critical to manage at the national level and maybe converted into a lookup service. Like Priyanka mentioned, some of the registries. I'll pick up one example: drug index. So drug index will have to be managed at the national level. It will have to be published, and it will have to be a lookup sort of a thing that is made available to everybody.
Correct.
The ecosystem will have to evolve to that level, and as I said in the beginning, that we are all in it together. We are at the cutting edge of the technology, and we don't have time because of COVID. We have to accelerate everything. So if we all work on it, then the lookup service will become available. So when the lookup service becomes available, it will have the same data elements as you have in your local, and it's only a pointer change. So you change the pointer from your local to the lookup service.
So if you would have visited the e-governance website, these code directories, they have already populated. Some of the code directories, specifically the demographic ones, are being populated in some formats that are usable by the developer community, by the application developers. Similarly, we are also working towards it, not only giving you access, but we are in the background, we are also working for publishing it in open in the formats that you can directly use. With respect to change management, MDDS is a standard written by Ministry of IT. The change management still will be from them. Whenever they update it, tomorrow the open community can grow to a level that they take the responsibility of keeping it updated as and when MIT releases a MDDS part 2 or version 2. So right now, at least in current scenario, at least this much, if you are able to put in your systems using these code directories, it is a good start. Because only once the vendors will start using it, Mighty will get feedback on it that they can update. Okay, then only they'll know, okay, this data is missing, I need to update this. That is a request, a demand should come from the industry.
Yeah, so the version 2 will, the request will be routed through Ministry of Health, and the custodian is Ministry of IT.
Yeah. So I'll just quickly show you a prescription note, because which is very, very critical if you want to do e-pharmacy orders, which you can readily use for this telemedicine era. It's the same, just some of the segments are not here. It will have drug allergies, patient information, active condition, and directly the RX details. It's a subset of the encounter note.
So the field type that you have marked as optional is really important here, because not everything would be captured in a single encounter or teleconsult visit as well. So that is
Right.
really helpful actually. Okay.
Yeah.
Sorry, what is this?
This is a prescription. This is a prescription note.
E-prescription.
So for a pharmacist to dispense a medicine, he would want to know the drug allergies patient has. He would also want to know active condition and some of the lab investigation that might interfere with how a medicine will behave. That's all. Or after taking that medicine, the lab results may hamper. There are certain notifiable labs. Only those labs need to always be here if there is an active lab order. Rest, it's normal prescription, which will have drug code, drug generic code, strength, all
No,
this stuff.
lab order is for a lab prescription, right? It's not for a pharmacy prescription.
So, I don't know if you had seen them, but if you really look at the West, where there are good CDSs for prescription, even in Vista EHR, these prescriptions are already, these CDSs rules are already built in. There are certain lab investigation that if requested by a doctor for a particular visit, that means the patient has to get it done in next 2-3 days. If a certain drug is taken, the result may hamper. So the result won't be as expected. So only those labs are to be notified here. And pharmacists should know before delivering the medication to the patient that, okay, if you take this before your lab investigation, it might hamper your result.
So he has to
Doctor-
inform the patient. That's what I'm saying. Okay.
Yes, yes, yes. Not all investigations are to be here.
Some of these basically are also triggered by the CDS's engine, as
Yes.
Priyanka rightly mentioned, and that is more important because the CDS's engine internally has to probably give you alerts on the drug-to-drug allergies and the drug-to-lab interferences. So all that is basically being managed by the CDSs, but this is being reflected in the prescription, is what you're trying to say, Priyanka, right?
Yes, yes, absolutely. There is a big gap in India for drug intakes. Yeah. Sorry. Carry on.
Priyanka, we can't hear you.
Hello?
Yeah, for about 30 seconds, we couldn't hear you.
Hello?
Yeah, your voice is a little flaky.
Yeah.
Yeah, yeah.
One more. Okay. I think so. In
Priyanka, your voice is breaking actually. You may have to re-log in.
network issues. What our technical team is also doing is trying to convert these e-objects into a JSON schema so that it is and extract. I'll just do that.
So while Priyanka comes back, any questions you have? Anything that we can answer in the meanwhile?
Hello.
Hi.
Yeah, this side Peter.
Yes, Peter.
Yeah, I just wanted to ask, like, I was looking into this e-object thing. There was a header. The header basically defines a unique identification for like the facility and the provider and everything. The header will be like the unique IDs.
Correct.
Right? And coming on to the segment part, like, is there any like description or PDF sort thing, like where it is mentioned like which modules are included in the segment? Like, for if I say a patient is going to a clinic for some like allergy test or something, are there any specific modules which we have to include in the segment for this allergy test?
So you're talking modules from the MVP perspective,
Yeah.
the MVPs that we have published, right?
Yeah, I just this segment thing, I want a like clear idea over that. This segment should
Interesting.
include which entities?
So while Priyanka comes back, any questions you have? Anything that we can answer in the meanwhile?
Hello.
Hi.
Yeah, this side Peter.
Yes, Peter.
Yeah, I just wanted to ask, like, I was looking into this e-object thing. There was a header. The header basically defines a unique identification for like the facility and the provider and everything. The header will be like the unique IDs, right?
Correct.
And coming on to the segment part, uh, like, is there any like description or PDF sort thing, like where it is mentioned like which modules are included in the segment? Like, for if I say a patient is going to a clinic for some like allergy test or something, are there any specific modules which we have to include in the segment for this allergy test?
So you're talking modules from the MVP perspective, the
Yeah,
MVPs that we have published, right?
yeah. I just this segment thing, I want a like clear idea over that. This segment should
Interesting.
include which entities, or
Okay.
shall it be like we are choosing it on a random basis, like?
No. There's no random there. So, inside the modules, you have data elements,
Yeah.
and so the data elements that are there inside those modules are the same data elements that are being captured in the e-objects.
Acha.
Okay, but the mapping at a module level is something which may exist somewhere. We haven't published it yet, but if you want, we will be happy to publish that also.
Like, if we are generating a JSON object, then while creating the segment part, is there any guideline like we should include this module for like short like this should be in that segment?
So it depends on how, right? So if you are generating microservices as per the microservices specifications that we have released, then you will be picking up the data element from that particular microservice.
Acha.
But if you are having a legacy system, then you will have to figure out, it's an internal mapping that you do. You have to figure out which is the nearest matching data element, and then populate this e-object segment, right? So in some cases, it could also be that um, it's not a one-to-one mapping; it is one-to-many mapping, and then you have to write a simple logic to sort of bring it together and populate the segment.
Actually, Peter, so the simple answer to that would be in the e-object sheet shared by Priyanka. She has basically listed the mandatoriness against each and every field. So whatever
Who decide this mandatory thing? Is it published somewhere, or like?
Yeah, so that is the specification that Access Health has been sharing is with the SEA members, right? So you have to just follow that as a guideline for now, and map your existing fields to the mandatory fields at least. So all the mandatory fields have to be filled in all scenarios at all times, right? The optional fields you may or may not really fill. That's really not relevant here for the discussion. But that mapping has already been provided by Access Health. Am I right, Dr. Pankaj?
Yeah, that's right. So we have provided all the mandatory fields. At the minimum, those are the mandatory fields that you need to map to your data elements wherever they may exist. In your legacy systems, it's going to be different, whereas in microservices, it's going to be different. Right?
Okay.
One more way of looking at it is like this whole FHIR object, we have different segments mapped to the resources, as I said. So patient resource, for example, contain all the patient demographic data. Now that can either come from your registration module or that can come from your ADT module, depending on your application design. But that contains all the patient demographic related data, and our mapping sheet is clearly mentioned in the remark thing like what it is containing. I mean, which information it is supposed to hold in which segment. Similarly, diagnostic report, for example, this is one segment. So diagnostic report contain your lab report related information. So then you can map it to your respective modules in your application, depending on which kind of module you want to submit that data. But segment has a clear specific role, what it is supposed to carry the information. So that is clearly highlighted, specified in the specification document.
Priyanka, are you back?
Yes, I am back.
Okay.
So sorry for that.
No issues.
Yeah. So I think, Krishan sir, can you please elaborate on the implementation side of it, technical implementation from an architect perspective?
So can you share your screen again? The same Excel.
You want me to share my screen, sir?
Yeah. Okay. So technically, so what the standard says is like this entire payload will be a JSON structure. This entire object will be modeled as a JSON structure, and FHIR will be the messaging structure that will be used. So what the sheet you are looking at is actually we are defining the specification or the schema of the JSON object. So that is so basically it describes all the data elements that are part of the different segments. Then it is describing the format, size, type of all the data elements. And then for the value set related things, it is specifying which code directory you can take the data. So what is the legitimate values it can carry. So it is ultimately defining the schema. And then, this entire document, you can call it as a FHIR profile. So it is like a FHIR profile document, which is defining the structure of the FHIR document that need to be sent. Now, technology-wise, FHIR can be implemented in multiple ways, 4 ways actually. So one is like you can submit the FHIR object over a REST API, which is a very simple case. So you need a kind of a server, which we call as a FHIR server, and which is a layer outside, on top of your existing clinical systems. So this FHIR server will contain, all the logic to kind of manage the resources, store the resources, provide the search operation on the resources, or kind of provide the history of the resources. Because one of the question you asked, like how to manage the history part. So if you want to see some changes are done in the data, you can still see the old history of the JSON objects. And then you need some mechanism to encode the data into the FHIR format. So this will be an encoding layer, which will take the data from your existing clinical systems, convert that into the JSON objects as per the schema what we are showing you in this Excel sheet, and then transmit it over the REST APIs. And you also need basically the decoding layer on the other side, which is actually taking the FHIR object and kind of parsing the FHIR object and then putting all the details, parsing details back into your database. So if you compare it with simply with the HL7 model, then you need a way to kind of encode the HL7 messages from your data, transmit the HL7 messages over some mechanism. Here we are saying REST API is a mechanism, and then decoding that HL7 message, which is actually parsing the JSON. So this is a client-server technology. FHIR is a client-server technology. So you need one side of the application, which is acting like a client, which is either receiving a FHIR object or kind of sending a FHIR object. The other side is acting as a FHIR server, which is hosting all the resource definitions, all the APIs, and as I said, the different operations like search operation or kind of history operation, and so on and so forth. So this is a very minimal thing, like I'm telling. So internally, FHIR provide the HL7 data types and the different value sets and all. So as part of the profile, we will be constraining these value sets based on the code directory structures that we are providing you. So we are saying like if it is a gender code, then it should be getting the value from this particular code directory, and we are giving the number of that code directory in the Excel sheet, and it can have only the acceptable values of M, F, or T. So when you will be sending your data to the FHIR server, there will be a validation logic in the FHIR server, which will check your FHIR object. And it will check like the values you have sent are correctly as per the standard which is supposed to be followed. So if someone is sending a wrong data in that, so it will show the message. I mean, it will show an error message, basically this is not an acceptable value. So ultimately, FHIR will help in the semantic interoperability part, so that we can send the right data to the other side and all the sides can understand data in the same format, and they could have the same common meaning of the data. So there are different FHIR libraries available, and a lot of open source libraries are available which help you to kind of encode the FHIR objects or decode the FHIR objects. All the JSON schema, we Access team are working on it, so we'll be publishing the schema of all the JSON objects for your use, which will be the next level description of this Excel sheet what we are showing you. So the more detailed and the concrete FHIR, JSON object structure of that. And then different APIs, this FHIR server will publish based on the standard FHIR, frameworks. And then you can kind of modify that FHIR, messages based on the extensions, or if new elements you're adding in that, or new code values you're adding in that. So those are the extensions. And we are also defining the extensions which are required in our profile structure. So this is a kind of minimal technical detail required, and that's really definitely a layer, a facade layer on top of your existing systems. So it will not be disrupting anything in your current design. So it will take the data from your existing system and then convert that into FHIR object and send it over the API. So that is the work of that layer. So please feel free to ask any question you have in mind. I've tried to kind of put a very
do you have a architecture diagram or something to explain this FHIR thing?
Yeah, sure. I will share that, and if required, I can have another detailed discussion on the technical part of that. I mean, if all of you are interested in it,
yeah,
we can have that.
Because we like to understand how it works in terms of the exactly what is it that we are required to do. When you say convert to FHIR, and is there a FHIR server required on my side, or is that my question?
Basically,
do we need to implement a FHIR server on my side?
The answer is yes and no, both actually. So ultimately, in the FHIR, as I said, everything is a kind of resource. So if you see like a JSON object, and you are sending something over the REST, then you need a URL and you need a request body and the response body, which is sending your data, and which is your current state of the resource. So ultimately, you are sending or receiving your data as the REST resources. Now, if you want to store these JSON objects for a longer time, the question you asked whether you want to store it or on the fly you want to generate it, then you need a FHIR server, because FHIR server will provide you storage into the JSON format with all the operations on that JSON, like search or delete or whatever.
So it's a database of JSON objects. But you said it also does a validation of this thing, right?
So this FHIR server does a lot of operations, which is like the validating the objects, or kind of searching over the object, searching the history of the object, and then doing the CRUD operations on the objects. So that is the responsibility of the FHIR server. So if you are doing all this thing, then you need a FHIR server.
Okay, fine. Got it. So, but we have to do all that. That means we will require that. That's what you're saying. Ultimately, since we have to do that. Okay. Yeah, that's all.
Some of the cases like some of the cases like, for example, we are submitting the data to PHR, or we are submitting the data to NHA, or some other government organization, some database, then they will be hosting the FHIR server, and we will be encoding the data into FHIR object and submitting to their FHIR server in those cases.
Repeat that. Sorry, repeat that. You're saying for NHR thing, right?
No, so for example, the claim object, that I want to bring the claim example here. The e-claim you're submitting to NHA, then e-claim will be the FHIR server will be hosted by the NHA server, and you will be converting your data into e-claim and submitting there.
Right.
But if you are doing the operations in your application side, then you need to host the FHIR server.
No, but see, for the provider side objects, I mean, not the claim objects, the provider objects. Okay. Now, for the provider objects, we have to provide the JSON objects, right? When a request comes for consolidation of data or something like that, for a particular patient's data is required. When a request comes, so we have to provide that data, correct?
Right? Yeah. So if you are the provider of the data, then you need to host a FHIR server.
Correct. So that's why I'm saying. So that means we need to host, just to get an idea of what is required. Okay, from our side. Okay.
So I will share the technical details, and if required, we can have a detailed discussion separate in a separate session.
Yeah, that would be better.
Any questions?
Yeah, so there is one question from my side, yeah, mine this side. So you just like mentioned, like if one has to do something like COVID screening in their app, so like they will be like not be allowed to like save any free text or text data, let's say. So like in the recent release of NRCS, there are like only 7 to 9 concepts like which are related to COVID. So is there any other direction on COVID screening, or is there like any certain rules on that, like apart from the basic symptom mapping?
If you so there are two things. One, in India right now, yes, everyone is doing COVID screening. They are using their own set of codes, and that too restricted ones. With respect to a pandemic, you need to actually explore what are the more symptoms that can be there. So what you can use is either use a ICD-10 symptom list and diagnosis list for capturing symptoms, comorbidities, and diagnosis. So you have everything in place. With respect to Loink, there are just 2 to 3. While in India, there is only one test to be done for confirming a provisional diagnosis of COVID as a confirmed diagnosis. So with respect to screening, there is a very minimum set you have to enable, but we would suggest to enable the entire diagnosis list and symptom list. Don't restrict it to just saying, okay, you can use the frequent symptoms on top of your screen in the front end. Similarly, similar mappings are being published by SNOMED also. They have also published all the symptoms and diagnosis and procedures, but that is more useful on a hospital side, because hospitals are the only one who will actually prescribe procedures to manage a COVID patient. Till screening, it's okay if you can just use basic demographics using MDDS standards, and on top of it, a symptom diagnosis list using ICD. With respect to lab, there is only 1 or 2 tests available in India. So just enable those. Dr. Pankaj, you want to add anything?
Yeah. Okay.
Yeah, that's right, Priyanka. When you are getting the data from the hospital side, that is when you will have comorbidities. You will have a lot of signs and symptoms that you may not want to miss, especially in epidemics like this. So that is where you will need a master list of signs and symptoms that you should sort of make it available, and code all the signs and symptoms.
Okay.
Yes. So the easiest use case is try to use this encounter at least for screening, and you'll get to know the result.
Okay.
Yeah.
So signs and symptoms are a difficult piece in any case. Even for a hospital, other than a medical college, usually signs and symptom details are not captured. So if it is not captured, then you can't codify it.
Sumit, anything from your Rajasthan experience on COVID screening and management?
No, as Dr. Pankaj said, right? So the most important data point for the government is the statistic and the report and the analysis. At the end of the day, they are really least interested in in filling out all the technical or the clinical information. But as Dr. Pankaj mentioned, there are a few medical colleges where they are ready to enter the clinical information. So wherever we get that information, we basically get it in. Otherwise, we just assume that it's not there, because you can't really force the government doctors to really fill it in the system, right?
Thank you. Thank you for
And
the
so on
insight.
the other side, what we have done is on the Janta Clinic experience, what we have done is we have tried to enforce it on the doctor. So that is where maximum clinical information is getting captured. So if you simplify it, then probably it is easier to make these government doctors fill in that information. But otherwise, it is difficult, as I said.
True.
Yeah, true.
So, any questions? Or we are happy to connect again on a separate call with the team if you want to have a detailed, more discussion with doubts and clarifications. You can absorb this for now, and then we can again connect. You can reach out to me anytime.
Yeah. So Priyanka, there was one request on a fire session. So maybe that is something that we may want to do. That, how do you handle the fire side in terms of the objects flowing between different systems?
Sure. So, we'll schedule the discussion then. Yeah.
Okay, sounds good. So, do we sort of wrap up for now then, Priyanka?
Yes.
If there are no other questions.
I think there are no other questions. We can wrap up the session with a note that as soon as we have the JSON schema ready for these e-objects, we will be sharing over an email or through the public forum that we have. We'll definitely share it to respective whoever attended this call, all the vendors and government partners. And then maybe we can have one more discussion when you actually look at it from a technical perspective and your feedback.
Okay. Thank you so much.